In Aussie MedEd, we've covered a lot of areas of medicine. One area of medicine we haven't covered as much of is general practice. It's such a huge spectrum of medical conditions that need to be covered. It's amazing general practitioners can keep track of it all. Consequently, over time, general practitioners have become more super specialised in their areas as well. And one area is women's health. Well, today we're lucky enough to be joined by a general practitioner who specialises in that, Dr. Ingeborg van Leeuwen, also known as Pinky to her friends. Pinky's going to talk to us about her medical practice in women's health, and also what other areas she covers. Good day and welcome to Aussie MedEd, the Australian medical education podcast, designed with a pragmatic approach to medical conditions by interviewing specialists in the medical field. I'm Gavin Diamond, an orthopaedic surgeon based in Adelaide, and I'm broadcasting from Ghana land. I'd like to remind you that this podcast is available on all podcast players and is also available as a video version on YouTube. I'd also like to remind you that if you enjoy this podcast, please subscribe or leave a review or give us a thumbs up, as I really appreciate the support and it helps the channel grow. I'd like to start the podcast by acknowledging the traditional owners of the land on which this podcast is produced, the Ghana people, and pay my respects to the elders both past, present and emerging. I'm very pleased to be able to welcome Pinky to us. Pinky works in general practice in Brighton area, but also practices up in Alice Springs in women's health. Her subspecialties include women's health, children's health, as well as Indigenous health and lifestyle medicine. Welcome, Pinky. Thank you very much for coming on board.
Thank you, Gav, for having me. I'm very excited to be here.
Perhaps you can actually start off by describing what women's health actually is. What main conditions does it cover in general?
As you said, it covers a broad range of conditions. If we start from a very young age, it's the prepubertal girls going through adolescence with menstrual problems, heavy periods, irregular periods, and other aspects of adolescent health, especially in the females. And then through to adult women who come in, for example, for advice on fertility, or for preconception advice, and then through to pregnancy. I am lucky enough to be able to cover a shared obstetric care, which means that together with public hospitals, we share the care of pregnant women, and most of their antenatal visits will be with a GP. And then from 36 weeks onwards, we send them back to the public hospital, and that's where they have their babies. And then, of course, afterwards, we're lucky enough to see the mother with their pups and try to support them as best we can as general practitioners, all the way through, I'm just skipping a whole lot, of course, but supporting young mums, very important, and through to perimenopausal women, through to postmenopausal women and the elderly women. It's too much to explain in a podcast, really, isn't it?
Well, that's a huge area to cover. And as you're talking about women's health as well, I recall that you also look after Indigenous health and also lifestyle medicine. How do you keep abreast of all these latest developments in these areas and keep up to date with this area?
Of course, that is a frustration I think that a lot of general practitioners will share with me. You know a little bit about a lot of things, and perhaps with women's health, I know a little bit more about that particular area, but it's still difficult to be an expert in everything. So it is always trying to read, to go to conferences, but also to accept that you won't know everything and that we have very good specialists that we can refer to if need be.
Why did you choose to go down the path of women's health? What was your main reason for doing so?
Well, trained in the Netherlands, and I always wanted to be an obstetrician gynecologist. And I went to the United States to do some research in obs-and-gynae, in endometriosis and recurrent pregnancy loss, still with the intention to do obs-and-gynae. Came back and worked as a service registrar for a year and a half. And then I fell in love with a surgeon, and we thought we would have children. And I thought that's a little bit difficult, the huge time investment, and I thought, I think I'm going to be doing general practice, but I will try to focus on women's health a little bit as well.
Perhaps you can describe a typical day in a general practice looking after women's health. What's your typical day? So for those thinking about heading down this path, they've got an idea of what it involves.
Well, of course, I'm mostly a general practitioner, so anything from an itchy earlobe to tinea to a heart attack to a dog bite can walk in my door. But I also have a lot of women who come in for advice, and I have some procedures that I usually do. Apart from talking, is some doing as well, which I'm sure you would like as a surgeon yourself, Gavin. So usually IUD insertions and removals, implanon, but also an ingrown toenail. And then, as you mentioned before, I travel to Alice Springs every 4 to 6 weeks to do mainly women's health and IUD insertions there.
So as a general practitioner, are you working 5 days a week, seeing patients non-stop? Are there administration aspects of your job as well, or are there other areas of training that you have time, or how does it actually work in general practice?
It's tricky because the admin you'd have to do in your own time, and I do that in the evening, sometimes on a Saturday. Sometimes I will do some phone calls, some telehealth consultations in the weekend as well, especially when I'm in Alice Springs. I still have to call my patients in Adelaide and vice versa if I have results that are abnormal. But it does involve a little bit more than just your 9-to-5 job. Yes.
And there is quite a shortage of general practitioners worldwide. And I'm not sure why people are choosing to not go down this path, because it is quite a rewarding job looking after patients from the young as they get older. What would you say the most enjoyable part of your job is?
I absolutely agree. It's never a boring day. And you have the opportunity to do the things that you like even more. So as you said, I have colleagues who do a lot of musculoskeletal pathology, who do palliative care, who are passionate about urology, skin excision. So that's the good thing. You can have your area of interest. And it is a shame that not more medical students choose general practice as their profession.
Well, hopefully this will help inspire them.
I hope so.
Yeah. What are some of the more common things that you see day in, day out?
Contraception is a huge deal. I think there are a lot of women, especially young women, who seek contraception who are not aware of the new options we have. For example, IUDs are very suitable for young girls as well. And a lot of them seem to believe that you have to have had children to be able to have an IUD, which is not. And I see a lot of mental health and a lot of girls seeking advice about simple things about their body that they're not aware of, who are very conscious of their body, or frustrated about their body, who feel that their body image is distorted. So it's good to give them advice, and that's where the lifestyle medicine comes in handy as well.
Can you outline to me what actually lifestyle medicine involves? Is it part about preventative medicine, about looking after general health as well of the patient, or what do you consider as lifestyle medicine encompasses?
It is both prevention of chronic disease, but also treatment. And of course, sometimes it won't be the only treatment, and there will be tablets involved or other procedures, but it definitely should be part of the management of prevention and treatment of chronic diseases.
Okay, so you're not only doing women's health and Indigenous health, looking after children, so adulthood and then to older age, but also you look after preventative medicine as well. It's quite a busy job you've got there. Must be quite enjoyable, but also taxing as well.
I am very busy, but my mother used to say you have to pick a profession that you love and it won't feel like work. And that's right. It doesn't feel like work. I enjoy it. Okay,
so you talked about the mental anguish of body image issues, and this obviously causes a lot of problems in women's health. But also, what about monetary issues too? There's a lot of monetary pressures at the moment. We come out of this COVID era. Is that causing a lot of anguish and mental issues at the same time as well, and double impact?
Absolutely. I think any general practitioner will deal a lot with mental health. I don't know exactly what it is, why there is such huge problem with anxiety and depression. And it is very rewarding to discuss those things. The good thing as a general practitioner is that you don't have to fix all their problems in one consultation. You won't have time for that. So you can always get them to come back and book a longer appointment, organize a mental health plan for them, refer them to a psychologist if need be. But also, sorry to have to mention lifestyle medicine again, but exercise as treatment for mental health problems is very important, and talking about their diet and body image in general, as we mentioned before.
So what's a pathway for a medical student heading down the path of general practice and then into women's health? How do you actually head down this pathway? Are there any particular training courses or other aspects of training that a general practitioner has to do as they head down the path of women's health? I'd like to let you know that Aussie Med is sponsored by OPC Health, an Australian supplier of prosthetics, orthotics, clinic equipment, compression garments, rehabilitation devices for doctors, physiotherapists, orthotists, podiatrists and hand therapists. If you'd like to know what OPC Health offers, visit opchealth.com.au and view their range online.
I think there are a lot of ways where you can arrive with this as your area of interest. As I said, myself, I trained a little bit in obs and gynae and did lots of deliveries in the Netherlands. But I think the Royal College of GPs also provides modules that the registrars can train in to arrive with that as their special interest.
And of course, you probably get support from other colleagues along the way.
Yeah, we have a WhatsApp group through Medcast, and that's very helpful. You can't do it alone. And I've got a couple of very nice gynecologists that I can always call. Thank God.
Yeah, that's the great thing about medicine. It is a team approach. So what is your general approach for treating delicate topics? You've talked about the mental anguish. Also, on one we haven't touched upon is also a lot of domestic violence issues now and violence against women, which is terrible. We're hearing more about it in the media. Yes. What's your general approach to dealing with these sort of things?
Of course, the first thing is to think about those things, to think about domestic violence. If you don't think about it, that it could be happening, you will miss it. To then say, if it's a young girl, to ask for permission to speak with her alone, or if someone comes in with their partner, to see if you can speak with the patient on their own without their partner, and to gently probe and ask to see if there are symptoms and signs of that, and to offer them help. I think the main thing is to not be judgmental or to try and solve it for them. They might not be ready for that, and offering your support now, but also in the future is really important so that they know that they can come to you when the time's right.
Presume you'd always make another appointment at some stage for a follow-up in that scenario? Or?
Absolutely. So if they know you're open for it, we definitely screen pregnant women, because then it's not enough to just keep your eyes open. Then you have to actually ask, because it's sadly quite common in pregnancy, domestic violence. So it's really important to screen for that at that time.
Right.
Yes.
There's a lot to watch out for.
Yes, but the good thing is we know them. Hopefully we know them. We know their background. Sometimes we know their parents. We know their history, and we have time as our friend. And that really helps. We don't have to solve problems, as I said before, in one consultation.
Pinky, what's your approach to dealing with lifestyle issues as well? Obviously, a major issue at the moment is raised BMI or some obesity, which can cause chronic problems in later life, as well as other issues that can occur, or smoking and other drug-related conditions. What's your approach to dealing with all these other lifestyle conditions in medicine?
That's always tricky to balance your time. There's never enough of it, of course. Usually when they come in with an acute problem, I try to, of course, address that first and then find some way into my lifestyle prevention health check point. And usually I ask for permission. Can I check your blood pressure? Is it okay if I check your weight because it is relevant for your acute problem, for example? I offer them a blood test, and most patients, when you ask for permission and ask it in a non-judgmental way, are quite open for it, I think. I think they expect it, perhaps.
Yeah. And the other things too are smoking and vaping. What are your thoughts on dealing with that and how you address that for any person coming through the process?
Well, you have to screen for it. So, now you don't just ask for if they smoke, if they use illicit drugs, if they drink alcohol, but also do you vape? And if they do, then I will tell them in very clear terms that this is very unhealthy and a threat to their health, and that I would recommend for them to quit.
Yeah. And are there any particular tips I can learn from you to help approach that issue?
Ooh, I think if there is a particular acute problem that they came with and smoking has an effect on it, I can use that for a reason for them to quit. But of course, as we learn as general practitioners, you want to assess first if they are ready to change their behavior. And if they're not ready to change their behavior, you don't want to waste your time trying to convince them. You can give them the facts and tell them to come back if they want some help in quitting. But if they're not ready to quit, then it's a waste of your energy. And I would give them some handouts and some phone numbers, like the quit line, things like that.
Let's say a patient comes through to you, a lady who wants a general screen to make sure she's okay. She's thinking about trying for a child and she hasn't had any success. What are your general approaches to both dealing with the initial problem of the lack of conception, but also just general checking for lifestyle issues too that may affect her long term?
There's a lot of topics to discuss with that lady. First of all, I want to know how old she is, to see how long we would let Mother Nature do its thing to see if she would fall pregnant naturally. If she is less than 30 years old and she has tried for 6 months, I wouldn't be so worried. And I might tell her, after checking, of course, what her menstrual history is like, to maybe try a bit longer. But of course, if she is approaching 35 to 40, we don't have that much time. And I would be in a bit more of a proactive role. I would check obstetric history, menstrual history, as I've discussed, and also family history. Are there any chromosomal or genetic conditions in the family? Since November last year, I believe we now can offer genetic carrier screening to women who are in the reproductive age, ideally before they fall pregnant. But if they are already pregnant, we offer it as well, but there's just less options. So we offer them genetic screening for cystic fibrosis, Fragile X, and spinal muscular atrophy. And I would check, as you said, blood pressure and body mass index, see how active she is, what her lifestyle in general is, and tell her that that can have an impact on her fertility. And her husband's or partner's health is also very important. We forget the partner usually, but apparently that's paternal health is very important as well. And then we would offer some blood tests. We would check if rubella antibodies are significant, if she's had varicella, chickenpox. We would check vitamin D levels, iron levels, screen for STDs. And I have forgotten quite a lot, I'm sure, just telling you this on top of my head, but I would check my little checklist.
Well, fairly extensive, so there's a lot to go through there. You wouldn't be able to do all that in one visit, of course.
No, but yeah, very important, good opportunity to do a general health check, really.
Moving on to the other lady, the one I might send along back to you, who's fallen over and broken her wrist at 53 years of age, for instance, and maybe she smokes occasional cigarette, and I'm concerned that she's broken her wrist and she needs an osteoporosis check. How do you approach that, and what's your general technique of dealing with those scenarios then?
That's one of my favorites as well. I think that it's important to think about it. So I think that I really appreciate the orthopedic surgeon thinking of those things. Sometimes I think they just might get treatment, but then somewhere get lost in the system and then not get screened for osteoporosis. But usually especially if it's a low energy trauma, I would want to know her family history. As you said, if she smokes, if she is active, what her body mass index is, if she's really skinny, for example. And I would certainly offer her a bone density test, and I would also x-ray her spine to check for vertebral fractures to see what sort of management we have to go from there.
Right. And once you've done your DEXA scan looking for osteoporosis, what's your mainstay of treatment in that scenario? Do you manage the full gambit up to biphosphonate commencement, or do you involve another specialty in that area?
Usually, unless there are complicating factors, we would manage that in general practice. Absolutely, yes. And I would certainly try for her to any of my perimenopausal and postmenopausal women to start doing some resistance training, because that's super important. We lose body muscle mass about 8% every 10 years, I believe. So that's really important for her bones as well. And I would then send her to the dentist to make sure she doesn't need any major dental procedures. and then discuss with her the options for treatment with bisphosphonates or the newer denosumab injections, calcium and vitamin D. Absolutely.
Wow. Excellent. Going on this sort of area of scenarios, the actual other one that comes to mind in women's health maybe is the lady who presents with some discharge and you're concerned about STD. How do you broach both the diagnosis and also then the prevention?
Well, of course, any woman in the reproductive age, we have a very low threshold for STD screening anyway. So I usually ask for consent and swab when possible and explain to them that this is important, that it is easy to miss, that they can be asymptomatic, and that it is very easy to treat, and if left untreated can cause fertility problems. So most women are happy with that. And if I am afraid that a woman might have an STD, I would certainly do swabs and a blood test to check for screen for STDs, and then make sure I don't do a phone consult, but get her back in face to discuss the results. And usually when I know the outcome, I will also print out some patient information sheets, because we then have to talk about tracing the contacts to make sure that this doesn't spread.
And which ones do you need to trace? Is it all of them? Or?
Usually would have to look that up, but of course the most common STD that I would see in general practice would be chlamydia, and that is a notifiable disease. And usually we would treat them and then repeat a urine test or swab, ideally a swab 3 months later, to make sure they haven't caught it again and that the treatment was successful.
Right. When I was going through, there's a lot of emphasis put on HIV, but that's better controlled nowadays. Is that still an issue, or are there other conditions or infections that we need to be more concerned about or that you are worried about?
I've only seen one case in my career so far, but we do screen for it, and see we do. But I don't think that in my general practice settings, HIV is a huge problem. Unfortunately, an upcoming problem is syphilis. So we do screen. We have very low threshold for that as well. And sometimes in pregnancies, we would screen multiple times.
Moving on to a different spectrum then, what about the lady approaching menopause and having issues with hot flushes and concerns about whether they go on hormone replacement therapy and the risks and benefits for that? That must be a very common scenario for you. How do you approach that?
Very common indeed. Usually, unfortunately, there's still a huge anxiety in women about HRT, which I think is very unjustified. Of course, the first thing will be to discuss lifestyle. You can see how lifestyle medicine comes in handy with all my patients. So a lot of women find that with a healthy lifestyle, their symptoms improve. And especially alcohol consumption can make their symptoms worse. But there is certainly a group of patients, of women who suffer a lot and who cannot sleep, who have hot flushes and night sweats, vaginal dryness, feel very anxious, and beg me to help them. And I'm like, let's start some HRT. That's absolutely fine. We know that the first 5 years of HRT, there is no increased risk of breast cancer, because that's the main concern that they have. If women have had a hysterectomy and only need estrogen and no progesterone, even after 5 years, there is no increased risk. And with the newer progestogens, like the micronized progesterone, that risk is also not increased after 5 years. If somehow we do a combined treatment with estrogen and progesterone more than 5 years, there is a small increase in breast cancer, but that's about the same risk as a woman drinking a glass of alcohol every day.
Really?
There are other ways to reduce their risk, and usually we would try to limit the duration of treatment for less than 5 years, if possible. But if they need it for longer, we would treat it for longer.
Yeah, it's amazing when you think of it in that term. Yeah. Certainly a lot of people might drink more than one glass.
Exactly. Yeah. And also there are the newer HRT options also make it possible to give them topical treatment. So a gel or a patch, that will also reduce their risk of blood clots, because we know oral can increase their risk of blood clots slightly. So So there's a lot of ways to reduce that risk and to really, I think there is certainly a role for HRT in women who are very symptomatic.
Yeah, when I was training, I used to hear about women who have DICs and curettages for excessive menstruation. Is that an issue nowadays with the current medications and things? Does that still occur?
It does still occur, but I remember a gynecologist almost complaining that the amount of hysterectomies have reduced significantly since the introduction of the Mirena, so the IUD with a little bit of progesterone in it, because that works very well around menopause when women have troublesome bleeding.
Excellent. In this era of diversity, obviously all the people I know who treat women's health are women. Is there a role for male doctors treating women's health, and are there many that do so?
It's funny, Gavin, why are there a lot of male gynecologists and male general practitioners who do women's health? I don't have the answer, but you're right. It's mainly women who do so. And I think there is a role for male GPs to do so as well, because we have a shortage of general practitioners, especially I need to travel all the way to Alice Springs to insert IUDs. And I wish there were more male general practitioners who would do insertions and who would be interested in women's health. So when I have medical students in my consultation room, I always encourage them to stay and to do a pap smear under my supervision, to watch an IUD insertion, etc. And I think they feel a bit awkward perhaps, but usually the patients are absolutely fine with that.
So it should be an area that should be encouraged for the future.
Absolutely.
Yeah. Okay. We haven't actually talked much about the prepubertal adolescent coming through the ranks. Do you have present with any issues at all that you see commonly and that are actually a minefield to watch out for?
Absolutely. What I see very commonly is a little girl with vulvovaginitis irritation who is complaining about discomfort while urinating, who is constantly itching her vulval region. And I have come across it a couple of times where they had presented in the emergency department, prescribed antibiotics for suspected UTI, but actually had vulvar irritation. So it's really important that you have a look because, of course, you have to check the urine, but it could just be irritation from running around in wet bathers, from not wiping front to back when they have done the number 2. It could be from bubble baths, very commonly, where they sit in soapy baths for an hour, and that really irritates that fragile skin. They don't usually get thrush, not before puberty and not after menopause. Women tend to not get thrush, but more other types of irritation. So in the elderly women, you may need to give her some estrogen cream, and in the younger girl, just pseudo-cream and stopping with wet wipes and things like that can be as simple as that.
Certainly in the older age group too, I believe urinary tract infections are very common as well. How do you treat those ones?
Right. In an older lady, I would certainly consider, especially if you can see a lot of vaginal atrophy, prescribing estrogen cream, because that can certainly help to prevent UTIs. And of course, making sure that they drink enough. Apparently, as we get older, our brain doesn't tell us when we're thirsty, or not until you're really thirsty. So making sure they up their fluids and just simple hygiene, that you don't need to use soap in that area, but sometimes a bit of estrogen cream local.
Right. A urinary tract infection, though, can present with quite significant confusion and loss of balance as well. In that scenario, do you see patients present in that situation where they're confused from a urinary tract infection at all, or is this something that more presents to a hospital situation?
We do see that, especially when there is already a history of cognitive impairment, and then they suddenly get extra confused and they can't quite localize what the problem is. Then it's, of course, very important to check their urine. Absolutely, because you can miss that UTI.
Excellent. We've covered a huge spectrum of things, from talking about lifestyle, actual regular scenarios that occur from all different age groups. Which part of the whole women's health spectrum do you prefer most of all?
I think it's the variation, the variety that I like most, and especially because I've been working in general practice for quite a while, I see this young woman first, then she becomes pregnant, and then she comes back with a little baby. And then we have to treat her baby who's become a child and then an adolescent. And then, so just all phases of life, being there to support them is really a privilege.
Excellent. Well, it's been fantastic having you on Aussie Med to hear about women's health in general. I look forward to hearing a little bit more about lifestyle medicine at some stage as well.
It was a pleasure to be here. I think we could talk another hour about women's health, but
it's a lot to get through.
Time is limited.
Well, thank you very much again, Pinky, for coming on Aussie Med. It's been great having you here today. I really appreciate your time, and I hope the general practitioners and the medical students get a lot out of it. It's certainly been really excellent hearing about this really important topic. Thank you very much.
Thanks for having me.
Thank you very much for listening to our podcast today. I'd like to remind you that the information provided is just general advice and may vary depending on the region which you are practicing or being treated. If you have any concerns or questions about what we've discussed, you should seek advice from your general practitioner. I'd like to thank you very much for listening to our podcast, and please subscribe to the podcast for the next episode. Until then, please stay safe.